Good evening and welcome to Preventing Pandemics from Policy to Practice. This is a socialized remotely signature event brought to you by Harvard's Office of the Vice Provost for Advances in Learning and socializeremotely.harvard.edu. Thank you all for joining us tonight. Our speakers will discuss the COVID-19 response in Africa, lessons learned from previous epidemics like the West African Ebola outbreak, and the future of global health. Our panelists include Ashish Jha, MD, EMPH, the K.T. Lee Professor of Global Health at the Harvard T.H. Chan School of Public Health, and the Faculty Director of the Harvard Global Health Institute. Dr. Jha is a practicing general internist and also Professor of Medicine at Harvard Medical School and a member of the Institute of Medicine, the National Academies of Sciences, Engineering, and Medicine. Ashish's research endeavors focus on improving the quality and costs of healthcare systems with a specialized focus on the impact of policies. Ashish has published over 200 various papers in prestigious journals and has a personal blog which focuses on using statistical data research to improve health quality. He recently spoke to the US Congress about the requirements for safely reopening the nation amid the COVID-19 pandemic. Ashish is joined by Dr. Raj Panjabi, the CEO of Last Mile Health, an assistant professor of medicine at Harvard Medical School and the Division of Global Health Equity at Brigham Women's Hospital. Raj grew up in Liberia and fled Liberia's civil war with his family when he was 9 years old, becoming a refugee in the USA. He returned to Liberia as a medical student, and then in 2007 co-founded Last Mile Health, a nonprofit organization working to save lives in the world's most remote communities by partnering with governments to design, scale, strengthen, and sustain high-quality community health systems. Raj currently serves as a Beck Visiting Social Innovator at Harvard Kennedy School of Government and was named by Time as one of the 100 most influential people in the world and one of the 50 most influential people in healthcare. And speaking of Time, our moderator this evening will be Nancy Gibbs, Director of the Shorenstein Center and the visiting Edward R. Murrow Professor of Practice of Press, Politics, and Public Policy at Harvard Kennedy School. Until September 2017, she was editor-in-chief of Time, directing news and feature coverage access across all platforms for more than 65 million readers worldwide. Nancy was the first woman to hold the position, remains an editor-at-large. During her 3 decades at Time, she was the author of more cover stories than any writer in Time's near 100-year history. Without further ado, let's begin discussing preventing pandemics from policy to practice. From policy to practice. Ashish, the virtual floor is yours.
Good evening, everybody. Thank you all for being here, and a big thanks to the organizers for pulling this together this evening. And it is indeed a huge pleasure and an honor to be here both with Nancy and Raj, and I'm excited about the conversation ahead. I'm going to get us started by just making a few high-level remarks about pandemics, where we are in the sort of thinking about the age of pandemics that I believe we are entering into or have entered into, and what the current pandemic teaches us and how we might look forward. So, but at a very high level, we'll dig into all of those. The thing that I think is important to understand is, as we look over the last century, the number of disease outbreaks around the globe have been increasing, and they've been increasing quite substantially. And certainly in the last 30 years, we've seen a big uptick. And that is why I've argued that we are indeed entering an age of pandemics. And so let's think about why those changes are happening and why they are not likely to slow down anytime soon. The phenomena that are driving it include globalization, a disease outbreak that starts in a small city or a medium-sized city in China becomes global within weeks, certainly by months. That phenomenon is, I think, largely a one-way road. We're not going to go back to a world that did not travel, that was not interconnected, that was not interdependent. Second is, with development has come encroachment into habitats that were previously where humans didn't go. And the reason that is so important is many of the disease outbreaks are zoonotic in origin. They are viruses that have lived happily with animals, but once they encounter humans, really wreak havoc on the human population. And third is economic development of China, of India, increasingly of the African continent. And that has meant both environmental changes, it has also meant changes in how people live lives, and it has also meant that those communities have become far more global and travel. All of these phenomena tied finally with climate change as an overlying feature means that we have not only seen a big increase in the number of outbreaks, but we should continue to expect that this pandemic, the worst in a century, will not be the last one in our lifetimes, and there will be many more. And it raises some very, very important questions about how we think about diseases, how we think about globalization, and how we prepare for these events, and the social impacts that these things have. Maybe just two more quick comments. One is that the last big outbreak that captured the world's imagination is the one that got me an opportunity to spend time getting to know Raj and his work, and that was the West African Ebola outbreak of 2014, 2015. And while that did not become a global pandemic, it certainly captured the world's attention and imagination. And coming out of it, it was very clear to pretty much everybody that we had dodged a bullet as a global community. The West African countries had actually suffered quite immensely in that outbreak, but the rest of the world had largely escaped it. But that was no guarantee of what things were going to happen in the future. And so there was this very large concerted effort to build an entire global coalition to prevent the next pandemic, to be much more prepared for it. And I think it's an important question to ask in those 5 years, did we make meaningful progress? Because here we are in the year 2020, we are in that pandemic that we've all feared. We are early in the pandemic, and of course, more than 300,000 people have already died, 5 million people have already been infected, and we are in the early days, and with a lot of challenges ahead of us. And I think what we are learning is that while there were important lessons that came out of Ebola that we did learn, and a few things that we began to implement, much of that agenda was left undone or not yet completed. And that is a part of the reason we are suffering the way we are. So I'm hopeful that we might be able to talk a bit more about this pandemic as we get into the questions and discussions. But let me turn it over now to Raj, really with the big picture perspective. That while this pandemic is indeed singular in its scope and size, it was both predictable, and really part of a broader trend that goes well beyond this one singular event. Let me stop with that and turn it over to my friend Raj Punjabi to pick up and talk about, well, wherever you want to talk about, Raj, wherever you want to go with this.
Well, thank you, Ashish. Those were really insightful points. I think that your points on globalization, on the rise of hotspots around the world, and our blind spots really in the global in the world, and in responding to those, I think really resonated. I want to build on that. I am coming off a few months now of working with our team at Last Mile Health to support our partners in training and equipping some of the folks that respond to this epidemic, community and frontline health workers across several countries in Africa. And many of them are standing in response to the COVID-19 pandemic, to the novel coronavirus pandemic. But I've also just recently have been taking up some volunteer shifts at the Mass General Hospital here in Boston, at the respiratory illness clinic, where we've been screening patients for COVID-19, and I've just been amazed again by frontline health workers here as well, especially my nurse colleagues. I was largely working as a nurse that day, although I'm a physician helping with testing and triaging COVID patients. And so, from those perspectives, one that is looking at Africa and supporting teams there, but also here in the United States, I share some of the same questions you have, and want to add a few more to our discussion. I think one is, I'm concerned whether we're being effective enough in our hotspots, wherever this pandemic is spreading. We know that many states are reopening, while many other countries are still on lockdown elsewhere. Right now, the virus has many of us on lockdown, and we know to put the virus on lockdown, to suppress it, that is, we've got to keep the economies open and return to a new normal. We all know that requires testing and contact tracing and treatment and isolation. That's increasingly becoming obvious. The science has been there for many years, even with other epidemics. But my concern is that a lot of the reporting on these activities from official sources in America and in Africa, it seems incomplete, incoherent, or invalid. When we look at the way testing rates are reported, contact tracing quality, or even looking at the way patients are getting isolation support during isolation or getting treatment. I worry that and this is very different than I think even the West Africa Ebola epidemic in that sense, is that there's not a clarity of focus on what metrics matter in those areas and whether we have trust in the official sources. So that is one concern to add to our conversation this morning. The second is a question about whether we've done enough to uncover our blind spots. We know that there's one epidemic that we're all focused on, the novel coronavirus epidemic, but as Ashish knows from his work in health systems, the novel coronavirus is collapsing health systems, both here and in Africa and elsewhere. We know that like during the Ebola epidemic, infectious viruses lead to infections among health workers. We're seeing that here and elsewhere. Fear amongst the public from going to clinics, even for routine conditions like heart disease. And this can lead to excess deaths amongst children, families, and those with chronic illnesses. In fact, just here at Mass General and Brigham and Women's Hospital, where I've been on staff, we're seeing half the number of outpatient visits compared to this time last year, as you know, even with the advent of telemedicine in place. And I think we're all worried, and we've seen reports of this, that this likely means that many of those with chronic conditions like heart disease and at risk for heart attacks or stroke are likely going untreated. There's a second epidemic there that's a hidden epidemic. And we've seen projections, and we're seeing it in our own work as well, of an increase in excess of child deaths of up to 45%, and an increase of up to 40% in maternal deaths in low and middle income countries due to the similar disruptions there. So again, we saw that during the Ebola epidemic. You'll remember, Ashish, the increases in untreated malaria cases and maternal deaths that happened in Ebola. And the third, and I'll pass it over to Nancy, the third concern and question I have is, are we doing enough to protect the health of our health workers? On Saturday on my volunteer shift, I was surprised. Mass General has done extraordinary work to ensure masks and face shields and gloves are all in place. And we had sufficient number of those as we were triaging patients and checking their vital signs. But I was asked to wear the same gown throughout the day because we were worried about the shortage of gowns in the hospital. And again, Mass General's done a tremendous amount as the hospital system here has, and they have resources to do it. I worry deeply about my colleagues in less resourced healthcare systems like in Africa. We know outbreaks start and stop in the community, and we know that community health workers, those recruited from their own communities, are critical to getting the testing rates up, the contact tracing rates up. They're going to be critical, and so at the same time, we know that there's a shortage of PPE, this protective equipment that these health workers depend on. Africa is losing out in a fight for market share to be able to get actually PPE imported into various parts of the continent where domestic production is insufficient. And we're seeing too many reports of community and frontline health workers, nurses and others lacking the gear they need to keep themselves safe. So this is the third area that I'm deeply concerned about. So again, three things. Are we effective enough in our hotspots? Have we looked carefully at our blind spots? And are we doing enough to protect the health of those health workers who can help us deal with both of those epidemics? Over to you, Nancy.
Thanks, Raj, and it's a pleasure to get to be with two leaders in public health who I admire so much. So I invite those of you who are listening who have questions to type them into the Q&A box. I'm going to ask a few of my own, and then I will start sharing yours. I want to pick up on something you each alluded to. Raj, you just talked about the importance of trust in official sources. And one thing that the WHO warned about early on was that we were looking at an infodemic, where people were being flooded with so much information, some of it reliable, much of it not. I feel like both of you, I can't turn on a television without finding public health leaders, including the two of you, nonstop trying to provide reliable information to people. And at times this has seemed like almost a losing battle given the creativity with which misinformation flows now. And so I'm curious about what you each has learned about what it takes to get good information to really reach the people who need it, and tactics that you have found effective, and what has frustrated or concerned you about just our ability to get reliable information out there that builds the kind of trust that you just referred to.
The challenge when I've done media, as I have spoken to the media, is a lot of the issues that are in front of us have a lot of uncertainty around them. So people say, well, what's going to happen when all the states open up? And people are looking for a simple answer, like it's going to be a disaster or it'll be fine. And guess what? It's not going to be a disaster and it's not going to be fine. It's complicated. And the problem is that the way, so one of the big challenges I feel like I consistently face is how do I communicate what I think is the nuance and where the science is and where the uncertainty is in a way that still feels useful for people. And to do it in a soundbite that's about 30 seconds, because if I go longer, the producer in my ear says, wrap it up. And that I think is a fundamental challenge, but it's really important that we figure out as public health people how to do that. Because if we can't do it, then we lose this game. Then other people will step in and say it's going to be a disaster or it's going to be fine. And they will be the ones. So I don't know how Raj has handled this. I've obviously tried to bring that nuance in, but it's definitely a consistent challenge on these things.
No, I think you're spot on, Ashish. And this is a lot of my interaction has been with the print media, and there it's slightly, frankly, a little more comfortable and easier because you can cite papers, you can add a complex quote. It's in the context of some very good reporting. Just our colleagues at ProPublica and Time, for instance, have put excellent reporting forward. So one of the other, it's interesting you raise that question as I think about how we're dealing with this in settings like Ethiopia, Uganda, Malawi, Liberia. There is a different approach. I mean, and I think there's something worth learning from here in the United States. On the one hand, the source of information there is just as complicated in terms of its the nuance that has to be presented. Often, communities, because of the lack of education, and especially in rural areas or in poorer communities, that's an added complication. The third is that, in fact, the public health authorities typically, even if they're skilled in communicating, don't have all the infrastructure, the communication infrastructure. So what they're doing a lot of is actually involving community organizations, hiring the neighbors of patients where outbreaks are, for instance, as the Liberian government's doing, hiring an additional 1,500 residents in Monrovia, where the hotspot currently is there. Ethiopia is doing the same thing. South Africa is doing the same thing. And those workers, I mean, they're having extraordinary results. In South Africa, a force of 28,000 community residents have been trained as community health workers. They've conducted 7 million screenings. They've screened 7 million people. That's 15% of the South Africa's wow. population. Yeah. And all of those folks have a lot of them who screen positive end up going then to testing centers. And then the use of digital technologies, I think, increasing as well. We've seen the Ugandan and Ethiopian governments take their own training content on for communities and frontline health workers and put them on smartphones and get them right into the hands of people. So this is sort of skipping the media in those situations, direct official government to citizen.
You both, I want to look backwards before we look forward, but you both referenced what we did learn and maybe should have learned from 2014 from the Ebola outbreak. And I'm wondering if you could go back in time and change just one thing about the last 4 months. We just saw a report this morning that said if we had shut down a week earlier, we would have saved 36,000 lives. And I recognize it's way too easy to do the sort of Monday morning quarterbacking, but we do have to learn from what has happened in the past for the next time, and you both said there will be a next time. So what do you wish we had learned and applied in this case that you feel like we didn't?
There are several issues, Nancy. Let me just throw out a couple. One is, one of the things I think we came out of the Ebola outbreak with pretty broad agreement on was the idea that this really, in this highly interdependent world, not just interconnected, but interdependent world, an outbreak anywhere was an outbreak everywhere. And that meant that we had to have a much more sort of solidarity-oriented global health policy that said, solidarity means that we're all in this together and that we have to make those kinds of investments. And there was a lot of interest in that. And I think there was a little movement in that. And then it sort of petered out as governments became much more nationalistic and said, we're going to focus on our country first. And that loss of momentum, I think, is really hurting us because it has really hampered the response globally in a way that is unnecessary. Vast majority of countries moved way too slowly on this disease. And that to me really stems from a mindset that at every part of this outbreak, and just one kind of thought on this, when it was in China, everybody said, well, it's going to be just in China, but it's not us. And then it was in East Asia and everybody said, well, it's East Asia, it's not us. Then it was Western Europe and people were like, oh, Western Europe, they have all those socialist health systems. That's why they're overwhelmed. It won't happen to us. And then like a month ago, it was, oh, it's the coast, it's New York, it's Seattle, it won't happen to us. And at some point, like the question is, what's us? Who's us? And second is like, at what point does this level of denialism that it's not us just become unsustainable? Because it continues to hurt us because we move way too slowly with that thing. And I thought we learned that lesson from Ebola, and the answer is we didn't.
I remember, Ashish has got actually put out a course on this with Harvard online that anyone can access. Some of folks online may have already even taken it. It's called Preventing the Next Ebola. What can we learn? So, he produced the course back in 2015, if I'm not mistaken, right around this time. And so it's a very poignant question and interesting to hear your reflections. I agree with that. I think that's one how does one create the urgency based on fact and not gets assumed in fear, right? Because that is part of the reaction. And one doesn't want to, President Sirleaf said this recently in an interview when she was asked about what lessons she wishes would be applied now. And she said, I acted too slowly. And I think she had many of the same human sentiments that this won't come to get us, and I think that's really saying we don't want it to come and get us as well. So I think one is just, science and rigor. It's not only something that hasn't been sufficient in the last 4 months; it's still not sufficient today. I look at one of the things that was poorly done during the Ebola epidemic, in West Africa. It took too long in those early months to get help in, but really the central issue to me, as I've thought about it more, it is not that there was a lack of activity. There was activity, but it wasn't coherent activity. It was chaotic activity. And one needs in public health operational clarity that comes from science. And we struggled to get that during the Ebola epidemic. It wasn't until October 2014, a month after this had, months after this has already gone viral. Spread really like wildfire across the 3 countries in West Africa. Routes had been shut down for airlines. Businesses had shut down. Many of our health workers have been killed. 8% of Liberia's health workers were killed. We already had a shortage. And a CDC forecast that showed over 1.4 million people, both of you remember this, could be infected if nothing more was done. It was at that point that the World Health Organization put out these very clear targets. 70, 70, 60. Get 70% of those who are sick into hospitals, 70% of whom have died in communities, and unfortunately there were too many deaths in communities, buried within 24 hours, and do all of that in 60 days. At that point, anyone involved in this fight, in the Ebola fight, had to justify and rationalize their activities against that clarity of targets. Today, we have states, health departments, countries in Africa reporting the numerators, the numbers of tests being done, but not the positivity rate. And when they do report the positivity rate, as we have seen with the CDC reporting just in the last few days, it's blurred. It's inaccurate. You look at the tracing rate. There's lots of talk now about getting contact tracers, but there's insufficient talk about ensuring that the percentage of, looking at the percentage of confirmed cases that are being traced. So, one could imagine an alternative trajectory. We could actually go ahead and set those targets now and say that 10% of your 10% of your tests should return positive or less. We could say that 90% of your confirmed cases ought to be traced, and you should be able to justify that. And we could have the transparency from our leadership to present that data, not a politicized set of data that makes one look good, look as if you're making progress, but in fact doesn't adhere to the science that confirms what is and isn't progress in epidemic control.
I want to come back to the politics of this, but first there are interesting questions that have come in from people watching. One is, it's May 21st, 2022, so it's 2 years from now. Can you tell us what your most hopeful vision is of the story at that time? And what's your most feared vision, where we are in 2 years?
You want me to start? Can I do the positive and you do the negative, Raj? No, I'm kidding. I'll do both. I'll do both. Yeah, I'll give you the most hopeful vision. So we're celebrating the first anniversary of having a majority of the world vaccinated. We're talking about really positive. I mean, it's not impossible. I think it's going to be hard, but we could have a vaccine and a large chunk of people vaccinated by next May. It's a little aggressive. It might take a little longer than that. And that we have come to realize the phenomenal economic and social devastation of disease outbreaks like this. We've decided that we are going to make important investments in improving the basic functioning of health systems and of healthcare workers around the world, because we have internalized the idea that a disease can go from Wuhan, China, to Lombardy to New York in weeks. And we have made major investments in platforms for science and technology around vaccines, around countermeasures, therapies, because we don't know what the next virus is going to be. But what we know is that we have to be much better prepared. And so it is both a global solidarity to try to really strengthen health systems, and a commitment from governments around the world saying, we're not going to do this again. We're not going to go through this again. Do I think that's possible? I do think that's possible. I think with the right leadership, and I don't want to turn this into an overtly partisan thing, but I don't see any appetite for that kind of an approach with the current president. And so it's hard for me to honestly see that could happen under a President Trump. And so that only comes about, I think all of that comes about if we have the vaccination can come about under either president, but if we have a change in political leadership. The nightmare is that somehow the vaccine efforts fail. I think that's low likelihood, that millions and millions of people around the world have died, that you've had nation states where political leaders have gotten infected and died. You have political instability, ongoing sort of a battle to try to figure out how do we develop better therapeutics, and that there is sort of true global disarray and a lack of global leadership. That's the nightmare. I'm much more hopeful than that, but that is on the possibility list.
Yeah, I agree with a lot of that. I think that, to me, in May 21st, 2022, we are celebrating the equitable distribution of a vaccine that reaches every last child and family that needs it, that's at risk, and no one's being left behind from that.
Can you talk a little about because that issue of distribution is a very thorny one.
Well, that's the nightmare, right? And let me go straight there, because as optimistic as I tend to be, I am deeply worried that this is the likely scenario, that in fact there will be a vaccine. In fact, there will be countermeasures or treatments for this virus, and we will have a group of people within rich countries who have access to that, and the poor essential workers. Others will get treatment late because of all kinds of economic and social barriers, a lack of insurance, for instance, which will have, and they will have a higher death rate than others. In countries like Africa, those in the 13 million kids and families still go without a single dose of any vaccine because they live in some of the most rural communities. And this is in the 21st century. This is with vaccines that have been around for 50, 60 years. They haven't reached these communities. So, I'm deeply worried that we will have a viral apartheid where you've got an entire group of people like HIV has been, that almost every other pandemic, HIV, tuberculosis, malaria impacts the poor more than it does the rich, even with the advent of vaccines, treatments. And so I think Ashish is exactly right. If we're able to invest, what I hope will happen is billions of dollars comes into pandemic health security. I mean, Ashish and others were calling for this years ago, that the average spending on pandemic security for the world, of preventing the next pandemic, is only about 50 cents per capita, according to a National Academy of Science and Medicine report back in 2016. To get it to the right place would simply be taking that 50 cents per capita spending, which is several billions, of course, when you think about the number of people on the planet, to just about 65 cents per capita. That's what it would have taken, as experts predicted, to prevent trillions of dollars of losses. I have to admit, as a physician who's not an economist, I sometimes looked in disbelief that a pandemic could cost trillions of dollars. In fact, it has, and we're continuing to hemorrhage. So I believe that if it's not now, I don't know when it would be, that billions gets invested. But I'm worried that a lot of that will go only to the therapies and the vaccines, and it needs to at least go there, and not sufficiently to distribution to ensure that every last person, I mean, the mantra ought to be until no one is out of reach. And that has to be the agenda. So there has to be health workers within reach of every last person, be they community health workers and nurses and otherwise. Surveillance is going to have to be done by them. The best emergency system, as we learned during Ebola, is not an emergency system per se. It's an everyday healthcare system that can be surged during a crisis. And we need to be committed to building that everyday healthcare system.
A number of viewers want to put you on the spot as faculty to grade the U.S. government's response to the pandemic from A to F. Government's a big place, so if it may be more helpful, and I think people are looking at, how do you think the CDC has performed? How has the administration in Washington, the White House, performed? How have government agencies performed in these last months?
I'll start. I'm not going to give the Harvard grade inflation. I'm going to give it to them, give it straight. I would give the federal response overall a D. A reasonable person could ask, why not an F? And I think there are features of it that have not been a complete and utter disaster. So for instance, I think that there have been moments when the White House task force under Debbie Birx and Tony Fauci have done some very good things and have put out some very good recommendations, have been very science driven. I think the federal government has done a good job on making investments in vaccines, and the NIH, which is part of the federal government, has done a nice job of coordinating trials. So there are features that I think help it not be an F. But the rest of it has been just chaotic, harmful. And I think the broad consensus in the public health community is that we would have likely been much better off if we had no federal response at all. Because the federal government has, and certainly out of the White House, there has been the kind of messaging that has, I think, actually been harmful. And I don't just mean like the kind of, obnoxious stuff like calling it the Wuhan virus, which is just racist and obnoxious. But I mean things like standing up every single day and saying, we have plenty of tests, anyone who needs a test can get it, wants a test can get a test. It has actually sent all the wrong signals to the market, because companies have been trying to decide, do I invest hundreds of millions of dollars to build a test? And if the president every day says we have plenty of tests and millions are coming, it makes no sense to invest in expanding testing capacity. And so it has taken an enormous amount of work to convince companies to pay no attention to the president of the United States and pay no attention to what's coming out of the White House. And that those, instead of trying to persuade companies and others to ignore the White House, I would have preferred if the White House hadn't spoken at all on these issues. The CDC has been inexplicably absent. Their work has been consistently poor. And what I know is that the fabulous scientists and experts at the CDC are still there. And so they didn't one day wake up and forget how to do this stuff. They're still great and they're still there. And so I can only imagine the pain that they are feeling watching the agency where they have worked. And most days I'm just thankful that they have stuck it out and hopeful that somehow, some way, the CDC will be liberated and be allowed to do what it needs to do.
So you're quoted in the Atlantic story today about the CDC merging the antibody and the viral tests, of saying, you've got to be kidding me. How could the CDC make that mistake? And that one just seems so breathtaking as just a catastrophe for any kind of epidemiology and accuracy. It's really confounding.
Yeah, and so you'd have to think that these extraordinary people who I've looked up to, who understand disease outbreak far better than I do, somehow forgot epidemiology and Outbreak 101. Possible. Or there's something else going on. And it's kind of like, you know, what I say about the inability of all the states to ramp up testing in a way that they need to, because the president has tried to say, well, this is a state responsibility. One of the things I often argue is you could go with the theory that we have 50 failing governors and 50 states who are all led by incompetent people, or you could go with the theory that we have an ineffective federal response. I'm going with the latter because that seems much more plausible than all of a sudden all 50 governors forgot how to do their jobs. It's the same kind of thing. So people are trying to pin this somehow on the CDC or the bureaucrats at the CDC. And to me, it's pretty clear that there is political interference from the White House and an inability of the CDC experts to do their job.
Raj, I wonder if you could address, a viewer makes the point that COVID-19 is disproportionately affecting women as they're on the front lines of the response in many cases, and asking, how do we build better health systems that are feminist and that protect the women who are providing that frontline care?
You know, every frontline worker I worked with on Saturday at Mass General, the medical assistants, the nurses, all of them were women. You know, when you look across the world at who are the nurses, who are the medical assistants, who are the community health workers, it turns out about 70% of the workforce globally are women. And there has been not only a predominance of them getting infected because they are on the front lines. One could say, well, that's just because they lack equipment and or training to use it. And that would be a partial analysis, in my opinion. There is a deeper inequality that has existed in the way women have been treated in the health workforce. A report from the World Health Organization about 2 years ago showed that it's largely women have been under-recognized and underpaid. In fact, when they ran the math on this, it was striking. When you count up the contributions of women in the health workforce, the economic output is about $3 trillion. They contribute $3 trillion of economic output through their caregiving and so they're, but a little bit more than half, about $1.5 trillion is unpaid or underpaid. And that's been going on for a long time. And we're seeing the impact of that now, you know, in reports in India, for instance, were quite shocking. A few weeks ago, reported in many media outlets. You know, the Indian government has 900,000 community health workers, all of whom are women. They're called Ashas. They have been going door to door to look for patients with tuberculosis, for providing primary health care, prenatal care to women, family planning services for many, many years. The Indian government asked them to go door to door to find patients with symptoms of coronavirus. But many of them, was reported, lacked simply even the face masks they needed, the face shields they needed, the gloves they needed. And we've seen that across several countries in Africa as well, that there just is insufficient protection of the health of these frontline health workers. So, when I see in a pandemic, as most epidemics do, they don't often, one can say, well, that's what caused the current situation. Often they are a reflection of the strengths and weaknesses and fault lines of society. And that's true in the health workforce as well. I think women have been underappreciated, under-recognized. And one way to correct that is really to think about, a lot of us are clapping for these health workers, and I do the same. But when we clap, we've got to remember to close the pay gap, right? We've got to challenge these employers to ensure that these frontline health workers, community health workers, largely women, are recognized, paid, fairly compensated, and valued.
I have questions for both of you about masks, and I'm going to bundle them together. One is it possible to create a mask that would completely prevent the virus from exiting or entering the nose and mouth? Is there any research on that device? Related to that, we've all now seen the suggestions that said that if you had reached 80% mask wearing, that would basically crush the virus in a matter of weeks. And do you believe that both that is the case? And what would it take to do that? Because that seems like a much simpler intervention than the economy crushing, $1 trillion costing lockdown that we've endured for the last 2 months.
So let me start with masks, and let me actually start with the second question first, because I think I have more to say about that. This is one where my views have changed, a sizable amount in the last 6 weeks, mostly because the evidence on this has been changing. And so 6 weeks ago, I thought masks were potentially important, but I was not convinced of the science or the data behind it. And we're obviously talking about mask wearing for not obviously in the healthcare setting. We're talking about people out or in stores or et cetera. I think given that we think about 50% of the transmission, maybe more, happens while people are asymptomatic, and very, very good evidence that masks, universal masking really can both reduce transmission, but actually the part that to me is very exciting is emerging data that the size of the inoculum that you get when you're infected may matter a lot in terms of how severely ill you get. And so masks reduce the size of the inoculum. So even if they don't prevent you from getting an infection, they might prevent you from getting very, very sick from the infection. They might cause a lot more mild disease. And there's almost a perfect correlation between mask wearing and mortality in countries in East Asia, much more so than mask wearing and cases, which is interesting. So given all of that, I have increasingly come to believe that the kind of universal masking should really be an important part of our strategy for helping kind of the country get back on its feet. Still got to do social distancing, still got to do testing, tracing. But as part of all of that, masking may be the thing that we have paid the least amount of attention to. And, it's funny because I've been on a couple of shows with people who've argued about this kind of being an infringement on their freedom. And my take is, I don't know how I feel about the government mandating masks. I'd probably be okay with it. But, what is the freedom you care about? If the freedom is about being able to go out, being able to go to work, being able to have your kids go to school, if that's the freedom you care about, then you ought to be wearing a mask. If you want to be free to be at home locked up because the entire economy has had to be shut down, then don't wear the mask. But you have to kind of redefine what you're trying to be free to do. And if we want the freedom to get our lives back, it has struck me that the data is really becoming clearer and clearer that universal masking can be a really important part of that strategy.
So I want to press you on that because one of the things I think that's been interesting and confounding is that the initial guidance was that mask wearing didn't make a difference. And so when that changed, that just contributed to even the experts don't know for sure.
Yep.
How much of that was the noble lie of worrying that people were going to buy up masks and hoard N95s and keep them from healthcare workers when actually they should have been recommending mask wearing? Or how much was it really that people's understanding of the value of it evolved as we understood more about asymptomatic transmission?
I think there may have been a part of it of that we didn't want to get people to go out and start buying up N95s, but I actually think, at least for me, I think a lot of it was the amount of evidence on asymptomatic transmission, what masks can do to the issue around inoculum. I didn't appreciate all of that 6 weeks ago. The science wasn't there. It's really become much clearer. So if the healthcare worker PPE issue didn't exist 6 weeks ago, I might have said, well, there's not very good evidence, but you might do better wearing a mask. But I didn't say that because I was probably worried about the PPE thing, but the evidence wasn't very good. It really has changed. And this is one of the things around communication that I think is very important. And I'm not saying I get this right, but I try very often to say, my views on this have changed because the evidence has changed. And you want my views to change as evidence changes. This is a novel virus. We're learning new stuff all the time. And if I was telling you what I learned in February, it would be a disaster. So that's been a bit of a challenge because people do bring up, oh, you said something different a month ago. True.
Yeah. Raj, can you, you both have talked about the chaotic lack of coherence in the response. Can you talk about the WHO, where you think it has performed well or badly, and whether it is up to the job? Will it be sufficient to provide the kind of global leadership and coordination that's necessary?
Has it been perfect? It hasn't. And I think everyone there, including Dr. Tedros, the Director General, would say the same thing. But has it been, have they tried everything within their power? Have they been effective? Are they necessary? Absolutely. And so, the facts are the facts. When you look at they were quick to recognize that this was a virus of significant concern. They had a vaccine developed that they offered to our country that this country refused, and of course it wanted to make its own a test. Apologies, but they had a test created for the virus and offered it to this country, and this country refused it, and that's okay. But once we failed at producing our own, we should have gone back with humility and asked for that test. They've also been vital in providing accurate information. And, Dr. Tedros has gone as far as establishing a solidarity fund, which has raised a few $100 million to provide the equipment, the testing kits, and training for frontline workers in parts of the world where there are insufficient numbers, and testing kits and equipment would be hard to purchase in poorer countries. So I think on many of those fronts, they've been incredible and necessary. And I think it's absolutely absurd that the American government has decided to withhold and halt. And frankly, it's a tactic of intimidation. And in the meanwhile, we are seeing other countries like China, which just committed $2 billion to the global response in coordination with the WHO this past week at the World Health Assembly, stepping right in. And I think that's unfortunate because it not only loses American leadership in the world, but frankly, it makes Americans less safe. It makes Americans like me less safe because we are not in the conversation. We're not aware of what's happening in other parts of the world where, imagine if the American and Chinese relationship had been different before the virus spread in Wuhan. If there had been more cooperation, how much more we could have known about the science of the transmission, including this question about masks. I think there were comments made in the media that the Asians, people in China were using masks because it was a cultural reason, which I found absurd and stereotypical. They must have known something from having gone through SARS and a number of other respiratory pathogens. Perhaps it was science that they knew, and we could have had access to that had we had better cooperation. Now that we've, ostracized hundreds of countries, or many countries through the WHO, I think that does a disservice to Americans.
Ashish, we have another mask question that's come in and is especially pointed. Will masks allow universities to open in the fall? Which is the doorway of what will it take for us all to be back in our classrooms come September?
Yeah, so my view is more optimistic than the average on this, and you should know that if you polled 100 public health people who've been thinking about this, I'm on the sort of 90th percentile in terms of optimism for what is possible. Obviously, it will depend on what's happening in your local community in terms of a level of community transmission. In places where there's an ongoing substantial outbreak, it's going to be very, very hard to bring kids back into that environment. That said, I believe a majority of universities can have on-campus activity this fall. It will not look like a normal fall. You can't have sports. You can't have, or certainly not with fans. You can't have classrooms with 100 kids. You're probably not going to have dorms with roommates. So you're going to have singles. You're going to have to do a lot of thinning of the classes. You're going to have to flip the classroom for large lectures. You may want to think about giving older staff and older faculty the semester off. One of the things I've been recommending, and actually Notre Dame just announced they're doing this, is come back in early August and finish in Thanksgiving. And then don't even bother trying to bring the kids back for December and just finish. If we do all of that, is there a guarantee? And by the way, and ubiquitous testing, which I think will be available by then. If we do all of that, is there a guarantee that we'll be able to get through the fall? No. Part of it is that kids, teenagers, 18, 20, 22-year-olds are not great at social distancing. And so they're going to do things that are what they do. And that said, I think there's a very good likelihood that most universities could get through the fall semester. But it's a risk. And I would say that people have to communicate effectively. Yeah. That if people are willing to take that risk, I think it's worth trying.
Well, we haven't spoken as much about contact tracing in this, but that will be the other element, right?
Absolutely.
I mean, Ashish mentioned that the factor fundamental to this is how much transmission of the virus is happening in your community. So testing is going to be critical, and contact tracing is going to be absolutely vital. There's a few legislative bills that I hope will go through, including one from Senators Bennett and Gillibrand, which is asking for a national health force to be stood up that would hire hundreds of thousands of unemployed Americans to be contact tracers. And I think, if we can get behind efforts like that, we'll be better at testing and tracing, which will mean transmission at community level will be lower. And the policies that universities will have to put forward will be they'll have more versatility to pick policies that are perhaps, again, the most parameters of flexibility of freedom within safety, right? But if it's too much community transmission, your degrees of freedom for a university to choose policies becomes more narrow and narrow. So we all want that transmission to be reduced. Keep it there.
We are almost out of time, so this will be quick, but it's a hopeful note to end on. We have someone asking, is there anything we can do as a collective community to prevent another pandemic from happening?
Raj, I'll let you start this one.
I would, this is an election year. I honestly, and I'm not, I think that vote for leaders who care about statistics, who care about science, who are going to speak transparently. I think that's going to be clear, right? I mean, there is a link between us wanting viral suppression and fighting voter suppression. So I think that, stand up and vote. I think that's critical. And vote for folks, study the platforms on healthcare. That's going to be critical. And, in the meantime, I would just say, try to get more proximal to communities that are marginalized, whether it's through direct service or just by reading and getting to know people, because those are going to be the ones that are going to be the least likely to get their jobs back. They're the ones who've had the highest death rates. And I think there's going to be a long recovery for them. We can't turn our eye to that.
And let me add to Raj's really important list that, much of the action is at the local levels, the governors who are doing who are really taking the lead. And so while we absolutely need national leadership, and we can't fight this as 50 states all competing, we still need to hold our governors accountable for all these issues, to continue to focus on ramping up testing, tracing, and isolation. Isolation is something we haven't talked much about, but the idea of asking people to go be by themselves for 14 days because they were exposed, or if they're positive, that's I could probably do that. Harvard would continue paying me. I could probably afford a hotel for 14 days. Most people couldn't, or many people couldn't. So we need real programs that allow for that to happen, so people don't have to choose between infecting their families and keeping their families fed. So there's a lot of local policies that we can push for and advocate for. And I actually have come to believe that the way this pandemic is going to play out in this country is a small number of states are going to do a fabulous job, especially if we hold them accountable. And enough other states are going to see that and say, wait a second, we want that. And states are going to try to emulate each other. And that to the extent that the federal government does anything at all, it'll come there, it'll be led there by states.
Which states do you put it leading that?
Well, I actually think Massachusetts has been great on this. And I think California has been great. Ohio has been great. Maryland has done a very good job. Rhode Island has done a good job. So I just named 5 with 3 Democrats and 2 Republican governors. So I think this is the kind of thing where you can get Washington State. There's a group that are really going to do a good job, I think. And I think others are going to want to follow that lead because those states are going to be able to be more open. They're going to have more robust economic activity. And who doesn't want more of that? And that, I think, will hopefully bring others along. And we can hold, certainly in Massachusetts, we can hold our governor accountable for making sure that he's not just doing it for the entire state, but he's paying particular attention to the communities that have been hit the hardest and have the least margin for error in policy.
Well, I would like to thank both of you, not just for spending time with all of us tonight, but for the really extraordinary leadership you've been showing through this. It has been inspiring to watch and to be part of the same institution as you both. So I wish you both well. I thank everyone who joined us tonight for your very interesting and thoughtful questions, and to the university for making this possible.
Thank you, Nancy.
Thank you, Nancy. Thank you, Ashish.
Thanks, Raj.
Yes, thanks everyone. Thank you, Nancy, Ashish, and Raj. Thanks all of you who have joined us tonight. We hope you'll join us again soon for the summer edition of our signature events. Information, as well as recordings of this and other events, can be found at socializeremotely.harvard.edu. Goodbye, everyone, and good health.